So hello friends, welcome to my new video. So today I'm going to discuss with you all about a very important topic that we all should know, and also we should know about its workup protocol and the cause. So I'm telling about Ptosis. Okay, so I'm going to discuss with you all about Ptosis today. So it is the inferior displacement of the upper eyelid from its actual position. So here in this picture you can see this the upper eyelid actually dropping little downward if we compare this eye with this eye. So this leads to many complications to the patient. First of all, the cosmetic appearance of the patient is altered with the quality of vision reduced because the patient is normally if someone normal patient are having normal eyelid position and normal opening of the eye, but if someone is having dropping eyelid, it will lead to looking like a cosmetically it's not acceptable to the patient. So that's why it's quite giving some kind of effect on their quality of life. And also if this dropping of the upper is very much that it is crossing the visual axis, then the vision also get reduced, and if it is continued for a long period of time, then it can lead to stimulus deprivation type of amblyopia. So here the muscle that are responsible for the elevation of eye are two muscles are responsible. One is LPS muscle, another is molar muscle that I told in my last videos, right? So here molar muscle only contribute to of elevation of the eye. So the main muscle working for elevation of the upper eyelid is LPS muscle, right? So here so this is the classification of ptosis, where ptosis is classified in uh, two type: congenital ptosis and acquired ptosis. So acquired ptosis is classified into four types: neurogenic, myogenic, aponeurotic and mechanical ptosis. Okay, so congenital means ptosis if it is present from by birth, it is congenital. Acquired means if ptosis is there after the baby born, that is called as acquired. So here we will start from the neurogenic, then myogenic. Neurogenic, this type of ptosis. So here neurogenic actually mainly it is due to two things like Horner syndrome or third nerve palsy that I will discuss in the later slides. Okay, so this is the congenital ptosis. So congenital ptosis is when ptosis is present at birth, which is due to some kind of abnormality to the LPS muscle or due to weakness of the superior rectus muscle, because LPS and superior rectus muscle origin is quite similar, right? So here sometime congenital ptosis may be due to heredity also. Okay, so this type of things are called congenital ptosis. Now if I tell you about the acquired ptosis, so acquired ptosis, here I will start from the neurogenic, where mainly two things I will discuss. There is third nerve palsy and Horner syndrome, right? So this is the third nerve palsy, where the third nerve palsy, it is due to many reasons like vascular or inflammatory cause or neurotoxic disorder. So the third nerve palsy is present with ptosis, extraocular muscle restrictions, pairing of the lateral rectus and superior oblique and pupil dilated, called mydrese. So this third nerve is actually responsible for working of many extraocular muscles, except that lateral rectus and superior oblique muscle, right? So, and also it is responsible for elevation or working of LPS muscle. So if third nerve palsy involved, then extraocular motility will be restricted. Along with that, ptosis will be there, right? So another thing, that is this is the myogenic ptosis. Okay, before that, if I tell you about this Horner syndrome. So Horner syndrome is the condition that present with partial ptosis, meiosis and facial sweating due to disruption of the sympathetic nerve supply. So that is called as Horner syndrome. Okay, so here let's move to myogenic ptosis. So myogenic ptosis, so it is also called a form of congenital ptosis that may be seen from childhood, where there is some kind of abnormal functioning of the LPS muscle is there, which leading to ptosis or one or both eyes. So congenital myogenic ptosis is usually unilateral. Okay, so here I will first of all discuss about the myasthenia gravis. So here this myasthenia gravis, which is a neuromuscular junction disorder, where you can see this is the neuron, this is the muscle, and if there is some kind of disorder, like it is the neuromuscular junction disorder, where antibodies against acetylcholine receptor cause disruption of disruption of them, leading to unilateral bilateral ptosis when the neuromuscular junction get damaged. So here the neuromuscular junction of the LPS muscle, if it is get damaged due to these auto antibodies against acetylcholine receptor. So this type of things are actually happening, leading to some kind of damage to those receptors, and it is leading to abnormal functioning of the LPS muscle, and it is ultimately leading to ptosis. Okay, so another thing is Marcus gun jaw inking phenomena, where so it is actually the miscommunication between the third cranial nerve with the facial nerve. Okay, so this is the miscommunication in the third cranial nerve, which is responsible for innervation of the LPS muscle, and fifth cranial nerve, that is responsible for innervate the muscle of mastication. So when the person do mastication, there is change in PFA seen. So that is called as Marcus gun jaw winking phenomena, where you can see that if here in the normal stage the patient is having ptosis, but when the patient open her mouth, then PFH actually increase. So this is the miscommunication between the nerves, between third nerve and the fifth nerve. So third nerve is responsible for LPS muscle innervation and or stimulation of the LPS muscle, and fifth nerve actually stimulate the muscles of mastication. So these things are happening in case of Marcus gun jaw inking phenomena. So there is a disorder called there is also another disorder called blepharophimosis ptosis epicanthus inverse syndrome. So it is an autoimmune autosomal dominant condition that is characterized by the bilateral congenital ptosis and the shortening of the eyelid. Okay, so let's move to aponeurotic ptosis. So here aponeurotic ptosis, it may be due to post-surgical, or it is one of the most common type of ptosis seen in adult people. So it can be due to many causes like frequent eye rubbing or trauma to the eye or prolonged use of contact lenses, especially the hard lens, weaken the tarsal plate as well as the LPS muscle, that lead to dropping of the upper eyelid. Okay, so let's move to mechanical ptosis. So here mechanical ptosis is due to an weight, extra weight, that down the eyelid downward, like chalazion, tumor, or scarring due to an inflammation. All those things that is pulling or putting the eyelid little bit downward, that is called as mechanical ptosis. Now, if I tell you about the pseudoptosis, so pseudoptosis means there is no ptosis is there, but appearance looks like there is ptosis present. Okay, so here this is pseudoptosis. So condition that mimic ptosis, there is in like if I give you the example, then anophthalmos, dermatochalasis, brotosis, or contralateral ptosis look like ptosis to the patient. So it is called as pseudoptosis because the person not having actual ptosis, but the condition look like there is ptosis. So that is called as pseudoptosis, where you can see this is the extra skin fold is coming downwards. So apparently it is looking like the person is having ptosis, but this is only because of the aging process. So that's why the skin is looking coming downwards. So if we pull, then the PFH is within normal limit, that is 10 mm. Okay, in both eyes. So now I will tell you about the workup protocol of ptosis. Okay, so first of all we will start from history taking. So in case of history taking, at first as the patient ask the patient about the onset of ptosis, mean from what time the patient is having ptosis, and ask the patient about the severity of the ptosis, means how much the ptosis hamper the patient daily activity and lifestyle. See that ptosis is involved in one eye or both eyes simultaneously, and also note down any history of trauma, previous eye surgery, dry eye, thyroid eye disease, and history of eye rubbing, because frequent eye rubbing lead to tarsal plate thinning that lead to ptosis. And ask the patient also about the jaw inking, diplopia, etc. And also ask the patient about the family history of ptosis, that whether any family member is having ptosis or not. Okay, so this is the flowchart, where first of all you will do the history taking, then measure the visual acuity, do the refraction, that is the objective subjective both, and then do the acceptance, and do the ocular alignment, that is and this ocular alignment is including this cover test, EOM checking, all those things. So cover test is including direct cover, cover on cover, and alternate cover test, and EOM extraocular motility test, where you need to see the eye movement at 9 gaze. Another is ptosis evaluation, that I will discuss in the later slide, and then ultimately slit lamp examination, and take the apprehension tonometry and do all those things. Okay, so let's start the workup protocol. So examination start from the time when the patient entered to your OPD room. Look at the patient head posture, face turn, also see the chin elevation, which is mostly common for ptosis patient. Now, ptosis patient mostly use their frontal muscle to elevate the eyebrow, to elevate the lid. So there is frontal muscle overaction also seen. Rule out the telecanthus or shortening of the eyelid to rule out pseudoptosis. Along with that, see the proptosis is there or not, or anophthalmos is there or not, to rule out pseudoptosis. So another thing that you can add on your history is ask the patient about thyroid also. Okay. Now, this is the thyroid patient where apparently it is looking like left eye is having ptosis, but right eye is having Graves' disease, so that's why it is moving out. What that is called as proptosis. So it is looking like false appearance of the left eye is having ptosis, but this is the disease eye. Okay. Now this is the anophthalmos where the right eye is actually getting smaller, so that's why eyelid is dropping downward. Okay, but this is not ptosis, this is anophthalmos. Okay. Now also don't forget to check the EOM in all gaze, see whether there is any restriction of the eye movement present or not, and if you see any kind of eye restriction, then do grading those restriction. Is it -4, -2, or -3, -1, depending on the restriction of that eye movement, right? So you need to document all those things properly. And also perform the cover test to rule out strabismus, starting from direct cover, then cover on cover, then lastly alternate cover test. Okay. And see the presence of leg ophthalmos is there or not, because suppose the patient is having ptosis and also the leg ophthalmos, and after you didn't saw the leg present is or not, and this I perform ptosis, so that it can worsen the condition. Okay, so that's why do check leg ophthalmos here. And also check the Bell's phenomena and grade the Bell's. A good Bell's is always important for keeping the healthy cornea after surgery. Okay, so that's why always do check the Bell's phenomena properly. Now let's move to ptosis evaluation. So for ptosis evaluation, you need to keep in mind some things like what is MRD1, what is MRD2, and what is MRD3, all those things, right? So MRD3 is not that much important, but here you need to have to measure the MRD1 and 2. So MRD1 is the distance between the corneal central light reflex and upper eyelid margin, that is MRD1. So the normal value is actually 4 to 5 millimeter. MRD2, you can see the MRD2 is the distance between corneal light reflex to the lower eyelid margin. Okay, that is called as MRD2. And MRD1 plus MRD2 is PFH, that is palpebral fissure height. So palpebral fissure height is the distance between the upper and lower eyelid margin at the axis of the pupil when the eye is at primary position. Okay, so it is the sum of MRD1 and MRD2. Okay, so this is the ptosis evaluation. Okay, so here you need to measure the LPS function, that is called as Burki's method, where you need to instruct the patient to look downward. Okay, so here the patient is looking downward, and place the millimeter ruler any reading here, like you are placing here 0.5, so, or you can also place 1 here, and tell the patient to elevate the eye to the up gaze and see what is the elevation in this scale. If it is more than 15 or more than 14 mm elevation, that means the person is having normal LPS function. Okay, so another thing also, you need to check the marginal crease distance. Okay, so marginal crease distance, here the upper lid crease is the position of the upper lid crease to the eyelid margin. It should be 7 to 8 millimeter for males and 9 to 10 millimeters for female. So here high lid crease distance indicate congenital defect. Okay, another thing you need to test, so here that is called as fatigue test. Here MRD1 should be measured first and instruct the patient to rest for 2 minutes or 3 minutes. After that MRD1 to be measured again, and worsening of the ptosis is seen in case of myasthenia gravis or myopathy and all those things. Okay, another thing, a test is eyes test. So here in case of eyes test, an ice pack is applied to the closed ptosis eye for 5 minutes, and after that measure the ptosis again. If ptosis improves, then it is myasthenia gravis, and not improve, then it is ptosis. Okay. Do perform the Shermer test and evaluate the tear film status, as dry eye patients tend to rub their eye, lead to mechanical injury to the tarsal plate. Okay, and also check the corneal sensitivity. Okay, so thank you for watching, and don't forget to subscribe to my channel. Thank you so much.